Hi, everyone. I see we have some people rolling in here, joining us and getting all set up. I want to welcome you to the University of Utah Huntsman Cancer Institute Regional Program today. We are excited to have everyone join us. Just wanted to go over a couple of quick housekeeping things to kick off. That if you have questions throughout the program, you can submit them via the chat button below and we can answer them as we roll. This is going to be a pretty open session. We're going to hear from a patient this morning and his parents. And we're going to hear from Dr. Laura Lambert, Dr. Affolter, Dr. Soares, and maybe a couple others that might join us throughout. So with that, I want to say thank you to Dr. Lambert for hosting this regional program. We always love working with her. We're sad we can't be in person this year, but are excited to be virtual and have some new attendees that maybe don't travel to Utah ordinarily. So thank you so much, and thank you for joining in. And with that, I'll pass it over to Dr. Lambert.
Great. Thank you, Lauren, and welcome everybody. Thank you for joining us for the regional part of the symposium. As Lauren said, we are going to keep this pretty informal. There's not going to be as much scientific data floating around and high-tech research going on. But I would like to thank Lauren and the ACPMP Research Foundation again for hosting the symposium. I've been actually doing symposia like this with ACPMB for over 10 years when I was back at the University of Massachusetts, and this is our third one here at the Huntsman. So we're excited about bringing ACPMP and just the HIPEC program to the Intermountain West to provide care for people in this region of the country. I want to thank Dr. Affolter, who's one of our GI pathologists here. She's participated in our previous symposia as well, and she will be happy to answer any questions about pathology. And Dr. Heloisa Soares, who's one of our GI medical oncologists, who recently joined our group, and she's been a wonderful addition, and she's very knowledgeable about appendix cancer and can answer any questions from a medical standpoint. And also want to welcome Lawrence Marsco. I saw him recently. There he is, who's one of our nursing directors here at the Huntsman. Works very closely with the nurses in the post-surgical unit and is very familiar with post-operative care, immediate post-operative care for people who've had cytoreduction in HIPEC, and would love to at some point have him just comment on the past 2.5 years that we've had the program here and how that's gone and the impact that it's had for us at the Huntsman Cancer Institute. But without further ado, I'd actually first like to introduce Mark Camacho, and this is really one of my most favorite parts about these symposia. We've always invited a person who's dealt with appendiceal cancer, either personally or as a caregiver, to share their experience. And this year, I've had the privilege and the pleasure to meet Mark and his family. I've invited Mark to ask if he'd be willing to share his story about having cancer of the appendix, which I think you'll find is incredibly unique and remarkable. He's a remarkable young man. He's got wonderful parents who have been with him every step of the journey. And I'm going to let him tell the story in his own words now. Mark.
Hi, my name is Mark Camacho, and I have high-grade mucinous appendiceal adenocarcinoma. Yeah, probably the worst diagnosis ever. And so basically, until I was 13, February 17th, I lived life not knowing that there was this very large tumor that was growing in my belly. And then one day, it created a blockage in my large intestine. And so I went to an urgent care and got a liver function test to make sure it wasn't my liver that was the problem. It wasn't. It was cancer. And so went straight to the ER. I got a CT scan, found the tumor, and then they did an exploratory surgery, found that it was very huge amount of cancer and that it was stage 4. So after that, the plan for treatment was to do chemo that was for adults mainly. And here I am like, well, this is a very awesome place to be in, where I'm a kid and everyone around me is an adult who has this cancer. And so basically, the first thing that my parents did, as very good parents, was they reached out to Pittsburgh in like the Hillman Cancer Institute in Pittsburgh, Pennsylvania, and they coordinated them to see if there was anyone nearby who had expertise. Luckily, Dr. Lambert was here in Utah, so that was very nice. And so after all that stuff, we started chemo, and with a plan to have regular checkups, blood tests, and stuff like that. Everything was going super smoothly. And then after the 8th round, the CT scan showed that I was having just a phenomenal response. And so I had a laparoscopic surgery. During the laparoscopic surgery, well, I guess after is when I learned that chances, like without knowing the data from the biopsy tests, that I would not be having HIPEC and that I would probably pass away within a year. But after the biopsies were tested, it found that basically all of the cancer was dead. And so that was a totally new place to come from than, oh, tons of live tumor. And so immediately, Dr. Lambert called my parents and gave the great news. We celebrated that night and we scheduled HIPEC. And then going into HIPEC, I was just ready because I knew that after this, I'd be done for a long time. And so we did HIPEC. Recovery was painful because you can either choose the long route of recovery or you can choose a short route. The long route is where it's not as painful. You take lots of pain meds, but it's slow. The fast route is where you do painful, but really fast. And yeah, I chose the fast route. And so it wasn't that fun. And so here I am about 2 months after surgery, and I'm able to ride my bike. I'm able to have a full diet, and it basically things have almost gone back to normal. I can, there's a few things about my body that I know are happening because of surgery, but other than those small, tiny little things, you would view me as a normal person until I lift up my shirt. And so yeah, that's my story. And thanks to everyone for that take care of me, the doctors, nurses, my wonderful parents, and yeah.
Thank you, Mark. That was a great telling of the story. I think your story encapsulated so many different aspects of what we talked about in the symposium all day today. And if it's all right with you, we may come back to some of those things that you talked about in your story, if that's okay.
Yeah, that's okay.
Okay, great. But I want to give your dad and your mom a chance. One of the talks in the general session was about the impact of what going through all of this is like being a caregiver. And would it be all right if they just kind of said a few things about their experience?
Yeah.
You want to start?
Okay. Well, obviously this is, Mark's awesome. He's a great kid. He was born in New York, and so some of the side effects of chemo is that you get cold more easily, but maybe he's been able to handle it better because he was born in New York. Who knows? Anyway, he's a tough kiddo. I guess the thing is having an awesome husband. We just kind of shared it. He did the hospital, trips with Mark, and then I would be home doing the home care. We also have a younger daughter who's 5. And I was just really grateful that we could divide it that way because I can't sleep on an airplane. So hospitals are awful for me too, right? My husband can fall asleep anywhere, anytime. So I was really grateful that he did that, all those trips.
Yeah, I was really intrigued by the talk this morning about the caregiver. I mean, looking at the graph, I think I'm anticipating an increase in anxiety as Marks goes down, I guess, now that we know this. But, you know, it's been a phenomenally unique experience for our family. And in some ways, I don't think we've processed what it's like to be caregivers yet. We've just been so in the moment, really trying to solve this thing in this crisis, and seeing so many little blessings and opportunities along the way, that our perspective on Mark and on life and on what it means to be together is totally changed. And we're you know, so grateful that he was able to have HIPEC.
For Dr.
I mean,
Lambert.
A year ago, if someone asked me if I'd be grateful that my son would be able to have this surgery, you know, totally different. And so grateful for Dr. Lambert, who happens to be in Utah, and for the network of folks that we've been able to coordinate with. One of the most pressing things that I was anxious about early on, and still am, was not knowing or not having the time to figure everything out. Right? I'm a professor at BYU, and am very used to, in engineering, to really knowing my stuff and what to do and how to solve the equation. And this was an equation I couldn't solve. And just really grateful for the community that's out there that knows so much more than we do.
Thanks, Ryan. Yeah, I will just add my words to that. It was a little daunting for me, I think, to when I met Mark. You know, as you know, appendix cancer doesn't happen very often in people under the age of 30, actually, quite honestly. So Mark's condition is very rare. Like he told you in his story, he presented with a bowel obstruction. So as you heard from Dr. Levine, you know, when people have symptoms from this cancer, it is usually harder to treat at that point in time. So when I met Mark, he had already had surgery. He had an ileostomy at that time. So that was another part he didn't mention, you know, a 13-year-old managing an ileostomy, which he did unbelievably well. When the first day I met him, he was just very matter of fact about it, and, you know, was handling it remarkably well. And then he started on chemotherapy, and he started on really one of the toughest chemotherapies that we can give to people, and multiple rounds. And, you know, and his dad, that engineer brain, was going to work, and he was reading the literature and asking all kinds of questions about different mutations and targeting. Like, he just jumped right into that, trying to help us solve the equation, as he put it. And then as Mark was going through chemotherapy, we could just see how he was feeling better despite having chemotherapy. Mark, I know it was hard. The chemotherapy was not good, but I know you were noticing things were changing as you were going along. So we knew the chemotherapy was working and your tumor markers were getting better. And then, as Mark said, we got to a point where we needed to think about possibly doing the cytoreduction and the HIPEC. And so we started off with a laparoscopy. That was one of the things we talked about in the earlier session, as a way of seeing what's really happening. You know, we have the imaging to give us an idea, but to kind of really see what was going on. And so we put the camera in and looked around. And I have to tell you, when I first got in there, I was like, this is not good. We're not going to be able to get a complete tumor removal. But we took some biopsies, and just like Mark said, I was as shocked when I saw the results that pretty much it was all dead tumor. And so I called them, and we made a plan to go ahead with the surgery, and we did that a couple months ago. And Mark just like wrote the textbook on how to recover. I think he was out of the hospital in about 6 days, and really did just work as hard as he could to recover as quickly as he could. And it's been pretty amazing. So It's as his dad said, there's been a lot of blessings along the way, and some pretty remarkable things that have happened. So I want to thank you guys for letting me be a part of this journey with you, and to take care of you. And it's been my privilege, and I know we're not done yet. We're still going, but things are good right now. So I want to just stop there and actually bring in Lawrence, because one of the things that was sort of interesting with Mark's case was that because he is a pediatric patient, the Huntsman Cancer Center is an adult hospital, and we don't have children here, but we do have a children's hospital that's connected to our campus. And so the plan was to have Mark actually recover at the children's hospital, and we were set up with that. But I felt a little uneasy about him going to the children's hospital the first night after surgery. So I called Lawrence and said, Lawrence, is there any way we could get permission to have Mark stay with us at least for one night? And Lawrence went to work on that and talked to the folks in the ICU. And yeah, I was just overwhelmed, Lawrence, by how wonderful the nurses were, receptive to doing this, providing this care. And I think if you could speak to that, that would be great. Because I think it was emblematic of the type of care that you find here at the Huntsman Cancer Institute.
Thanks, Laura. Hi, Mark. I don't know if you remember, I stopped in to see you real quick after the day of your surgery. And I just wanted to make sure everything was going okay. You look fantastic. It's always great to see people you look really, really good. So yeah, 2.5 years ago, we really went on this journey with Dr. Lambert about bringing HIPEC to Huntsman Cancer Institute. And it has been an extraordinary experience to be working with her. Prior to her coming, we really did a lot of work on the nursing end, because we needed to make sure that, number one, we were able to do this procedure safely in the operating room, because we've never done something like this. So we worked with Laura from afar while she was on the East Coast, and really were able to hit the ground running once she came to Salt Lake City up here at Huntsman Cancer Institute. And it's been a really incredible journey that we've been through with her. We've done several patients, and the nurses are becoming really good experts in caring for our patients post-operatively. As you know, it's a very complicated surgery. It's a very painful recovery. And it's a little bit overwhelming for not only the patient, but also as the caregiver. As Laura had mentioned, that we don't treat kids like little adults, because they're not. We really believe that pediatrics are very specialized. But when I started looking at Mark's height and his weight, and making sure that the pharmacists were ready to make sure we had the medications that he needed, that nursing felt comfortable with it, that the ICU doctors felt comfortable with it. I mean, my first 2 years, I was a pediatric nurse, and so I realized that pediatrics is a specialty. They're not just small adults, but once we seemed to get all the ducks in a row, I felt comfortable that he be able to have his recovery in our ICU for the first 24 hours, because it was the best thing for him, as well as for Dr. Lambert to really look at him during that first 24 to 36 hours, but also knowing that he would be better served than at the children's hospital, because he is a kid. And he's just a really dynamic, wonderful kid. And so we really felt the best place for him to recover then would be at the children's hospital. But we now are trying to get Dr. Lambert's patients out maybe a day or two earlier, because we have what's called a Huntsman at Home program, where we actually have an advanced practitioner and us community nursing to really go ahead and keep a close eye on our patients post-operatively and try to get them home sooner rather than later. And I think that has also been a very successful program. Our home health nursing agency that we use have these great pathways to really care for these patients once they get out of the hospital and into a home environment. And that home environment actually may be a hotel, because Dr. Lambert really likes to keep her patients close for at least 1 to 2 weeks post-operatively. And so we are able to do that, I think, expertly now in a home environment once they get out of the hospital, and Dr. Lambert feels really comfortable with them leaving the hospital. And we have really great nursing staff here now, both inpatient, caring for these patients, the patients that are having HIPEC surgery, and really getting them up, getting them moving, making sure that their pain is under control, and then really having great discharge teaching so that they feel comfortable and their caregivers feel comfortable once they go home, and that they know what to do if or when they are concerned. And the clinic nurses that Dr. Lambert works with as well are become experts in these patients, caring for these patients. And the one thing that Huntsman Cancer Hospital has is that we have what it's called the Huntsman Acute Care Clinic, and that in the event that somebody does not feel good postoperatively, if they can't get in to see Dr. Lambert because she doesn't have a clinic that day, we can have the patient come to the Huntsman Acute Care, and Dr. Lambert or one of her team members can come see the patient in the Huntsman Acute Care Clinic. And so we understand how complex these patients are, and we're really trying to serve them from a lot of different angles.
Yeah, thank you, Lawrence. And I want to echo what you said. My transition here back in 2018 was seamless. You had really done all the work ahead of time, and it was so appreciated. I started on January 1st in 2018, and we did our first HIPEC on January 10th, and we were ready to roll. And the nurses, to their credit, put together a training program for themselves, a PowerPoint slide presentation that they showed me. I was kind of blown away by how thorough they'd been. I know you had gone out to the City of Hope to visit their program and to talk about the precautions that were needed around having chemotherapy, a patient that had just had chemotherapy, and all of that. And it's been amazing. And we've done over 120 HIPEC so far. So definitely the folks in the OR, the folks that I work with in the clinic, and the nurses who are taking care of these patients, both in the ICU and on the floor afterwards, are very familiar now with what to expect, what's normal, what's not, how to counsel patients and their families and support them. And they understand the rigor of this surgery that's different than other surgeries for cancers with the added aspect of the chemotherapy. So thank you, and thank you to all the support that the Huntsman has provided in allowing us to start this program. With that, I think we would just open it up to questions. I know Lauren has said to use the chat, but if there's any burning questions that people have, it's a small enough group, hopefully we can get to them. Or if there's any left over from the general session, Lauren, that we should try to address?
Yeah, so I want to just, before we jump into a new topic, I did want to have 2 questions for Mark and his parents while we have them. And thank you, Mark, for sharing your story. I know I got a little teary-eyed. I'm sure you tell it very well, and it had some highs and lows, I'm sure, and I'm so glad that you're doing well. And I know a couple of people wrote you in the chat saying that they're so happy to hear you're doing well, and thank you for sharing your story. I really can't wrap my head around being in your shoes at such a young age, but you handle it with such grace and strength. And so I wanted to ask 2 questions for both Mark and his parents. Mark, what is one piece of advice that you can share with other patients who maybe have gone through surgery or who haven't gone through surgery yet, that you could give to them that helped you, or, you know, just a little piece of advice?
So I would say 2 things. 1, always maintain a positive attitude. 2, just know that after surgery, it only goes uphill.
Love it. That's great. Those are awesome pieces of advice. And I want to now pose it to your parents, Ryan and Melinda. What's one piece of advice that you have for caregivers to share with our community today?
Melinda, do you have any good advice? I don't know what I'm thinking. What to...
Well, I actually wrote down probably the top 3 things, you know, for Mark's care. Number 1 was a great distraction, and being a teenage boy, computer games is like right up there. And so thanks to Make-A-Wish, he did get a new computer, even more awesome.
And a green screen, which you see here.
So he had a lot to look forward to, just when he started feeling better from chemo. Obviously, he had those mouth sores and whatnot. What was your favorite? Was it Listerine, rinsing with that?
Yeah, not necessarily a favorite, but necessary.
Okay. Number 2 was I went down to Artsy Willie's furniture place, and I bought him a small lazy boy because he's not a big adult. He's little, right? And anyway, and so he could just have different angles and whatnot. And then also, like, every day I gave him a foot massage, back massage, arm massage, feet massage. It's circulation sometimes on chemo, right? Make the and then the third thing was he's a teenager, so he loves to eat. So whenever there's like famine feast, right? Can't eat after the chemo, and then all of a sudden he can't eat. And so I try to like pack in the grains by doing green smoothies and whatnot. And then he needs a lot of protein because he's still growing. And so Chick-fil-A was like his favorite chicken ever. So they made, we kept him in business really good. What was your favorite Chick-fil-A?
Chick-fil-A.
There are Chick-fil-A stories that Dr. Lambert could tell you.
Oh, yeah. Like one time before chemo, I always had a last meal before I felt like not eating. And one time I ate so much Chick-fil-A that my stomach was distended.
She was like, "What's this on the CAT scan?"
I think for me, this is maybe not very practical, but to expect to feel things that you didn't expect, and to be able to do things you didn't expect. For example, we felt as a family a lot of gratitude at times in which it was really unexpected. Mark was leading us in that, actually. And how he after he was diagnosed, he said, "Dad, I am so grateful that we got," and it just blew my mind, because I was in this, my son's got this thing, and he says, "Now I understand why I felt the way I did. Now I know," and so hearing that, and I guess more generally, when people, allowing the little things to give you hope. We talked about hope, and that made a big difference for our family to do that. And having Melinda, my wife, she'd said some nice things about me earlier. Having a co-caregiver, a life partner, or a family member, or a faith community, it has been so crucial. Be able to stay up all night and just cry together, and hope together, and laugh together as a caregiver, so that I could go give my strength to Mark and read the papers that I wanted to read and talk to Dr. Lambert about, or whatever. But having that has been really critical. And so I don't know if that's advice, but that's experience that we've had that may be useful.
That's great. I really appreciate that, guys. I'm sure everyone in the audience is really touched just by hearing your small victories and hearing what kind of got you all through. Love the Chick-fil-A thing. I'm over here in Boston. We don't have many Chick-fil-A's as you guys do, but I'm right there with you, Mark. So thank you guys so much. I see that someone asked how old Mark is, and he answered, so he is 14. And if people have questions throughout that they want to ask Mark or his family, I'm sure they'd be happy to share with you guys. So with that, I'm going to kind of turn over. I'll start with questions that we have right now in the chat, just because those are current, and then we can kind of roll into some questions that I have for the panelists already kind of pre-posed that I think that everyone joining us today might find useful. So one of the questions we have is from Charmaine, and she asked, what changes have you made for visitation in light of COVID-19, other care aspects that might be affected by this environment?
I could probably answer that question. So it has been a journey. Let's just say this. We have navigated through the COVID journey very carefully, because our ultimate responsibility and concern was to make sure that we kept our patients and staff safe. So that was really priority number one until we learned a lot more about COVID. But we also, care from the heart. And so we did, when we started what we started was, in order for us to be safe, we had a no visitor policy. But within that no visitor policy, we embedded in it that if somebody was, like, for example, there are rare exceptions. We'll have a 17-year-old or a 16-year-old be done by a physician as well. Pediatric patients, we've always allowed a parent to be with them during that time as a visitor. And then we had some other exceptions. And so it was very hard on the staff as well as the patient, but I think it was even harder on families to not be able to visit. And this was both for outpatient as well as inpatient. Just recently, we have decided to open the door slightly in the inpatient world and a little bit more broad in the outpatient world. So right now in outpatient clinics, each patient is allowed one visitor to accompany them. And then the inpatient, what we're trying to do is to really limit sort of crowd and try to do crowd control. So we are now allowing one visitor to visit each day for 4 hours. So we have a very limited time for visiting hours from 4 to 8 in the evening. And we are having 2 visitors be identified for the family. This is just, again, because we still see rising numbers in our community. And what we're doing is trying to keep our patients and our staff as safe as possible, but at the same time, open the door now to visitors, because cancer affects not just the patient, it's the entire family. And we've always wanted to make sure that the visitors, that's part of our mantra. And it's been very hard on the providers as well as the nurses to not have the family. But we feel that we now know it well enough that if the patient is masked, the visitor is masked, and the staff are masked, we feel that we can keep everybody safe since it's a very limited period of time.
Yeah, thanks, Lawrence. It's been incredibly challenging. I think for me, one of the hardest things was going to see patients in the pre-surgery holding area, knowing that their family had basically dropped them off at the curbside and wasn't going to see them for another week to 10 days and not have any ability to interact with the team that was taking care of them except through the phone and stuff like that. It's been so hard. I'm grateful, as Lawrence said, we did have to be careful. There's obviously, a huge concern for COVID in patients who are immunocompromised, getting chemotherapy. We know that cancer patients are at higher risk of complications from COVID. So it was very important. But I'm so grateful that now at least a family member can come with the person and be in the holding area before surgery, and then come daily after that to be a part of their care team. And it's amazing how much the impact that COVID has had in so many different ways.
So another question we have, which is kind of still pertaining to COVID, is are you doing virtual visits with first-time patients who possibly want a second opinion on surgery? This is from Laura Nelson.
Yeah. Oh, absolutely. We definitely are. Being in the Intermountain West, we have people who come from such far distances. I think if you're talking about kind of finding blessings and things, I think the fact that we have figured out how to do medicine virtually has really opened up a lot of opportunity. I think that came up in the general session as well. And Dr. Soares, what are your thoughts about that? I actually think it's going to add some benefits that we couldn't imagine. I am happy to see people for a second opinion as their first visit virtually.
Yeah, thank you, Dr. Lambert. And thanks for having me. And Mark, you're amazing. What can I say? I email Dr. Lambert privately, and I said, I'm going to start crying. I think I held off well so far. So in terms of visits, yes, I am also a believer that, especially for second opinions, especially when someone is coming from far, at least the first contact can be virtually. As Dr. Lambert and all the team at HCI, we're extremely patient-centered, and we really recently just participate in a national effort to try to lobby that this will continue to be performed and allowed, because some of that is not us, as there are some limitations in insurance and payments and things that are above what all of us wanted to do, right? So we had lobby and wrote to congressmen to hopefully make that as a bill. So we have your back, and hopefully we'll continue to be doing very long-term second opinions virtually again, and at least one time. And then if things evolve, then obviously one needs to come and be seen in person.
Yeah, obviously the circumstances will dictate if somebody really does need to be seen in person or not, but it's amazing what you can do virtually. You can get a lot accomplished. So and I think there was one more question about COVID, Lauren, something about testing. So right now, we are fortunate. We have the saliva test here. Yay! So no more pituitary biopsies if you need to come in. But that being said, we are, Lawrence, correct me if I'm wrong, because it changes almost daily, it seems like. We like to have the COVID test not any earlier than 72 hours. So if somebody's coming in for surgery, you have to have a COVID test at least 72 hours before your surgery. And you can have it as far out as a week, as long as you quarantine in that time and don't develop any symptoms in that time. Is that correct, Lawrence? I think that's it.
Yeah.
Okay,
yeah.
Great.
Yeah, and we screen everybody coming in the door. You're not required to have a COVID test to come to a clinic appointment. But we do screen, and we ask anybody with COVID symptoms to not come into the hospital. And so, but we don't require for a clinic visit, but for surgery, Dr.
Great. Thank you guys so much for answering those. I know those questions sometimes are a little bit more specific to your institution, so it's good for those that are wanting answers specific to Huntsman. So I have a couple of questions geared up that I'd love to ask. The first one is for Dr. Soares. And I think this is a question that comes up a lot with our patients. When is systemic chemo appropriate? There's a lot of debate amongst our patients and also I know in the medical community as to whether it should be administered before, after, or both for surgery. What is your approach at Huntsman?
Thank you for the question, and I think it's what is our approach, and that is truly a multidisciplinary decision, which actually starts with Dr. Affolter, who give us the pathology, because depending on what our review of the pathology shows, Dr. Lambert, after the multidisciplinary discussion, might decide that, okay, this patient can go straight to HIPAC, versus whether if someone has a component of a high-grade adenocarcinoma, we feel that most of the time patients will be better served to start with chemotherapy first. Kajsa, I think it'll be great if you can comment on the differences, and how often do you see differences between the outside pathologies and when you review them here? Because I think pathology is the key, and so many times it's so important.
Yeah, so I think that would be my biggest plug, I guess, from my perspective is there's lots of literature on the discordance between kind of community pathology and large volume tertiary care type pathology review, and the literature ranges anywhere from like a 10% to a 50% discordance rate. It can be really high, and that includes both upgrading and downgrading. So sometimes what the community calls it at a large scale institution, we will have a higher grade, which would indicate chemotherapy. And sometimes the outside facility will have a higher grade, and we see it and we don't think it's that high. We think it's a lower grade. And so that will, again, better prognosis and also perhaps no chemotherapy. And so I think although the community is getting better as time passes with understanding terminology and the histology that correlates with that, there still is very good reason to have your pathology reviewed at whatever cancer institute you're going to be treated at.
Yeah. I can't emphasize that enough. You know, when somebody comes here to see me or Dr. Soares, you know, the first thing, you know, we always have the pathology reviewed by our pathologists who we know are familiar with the latest in thinking about how to define these tumors, how to categorize them, what they're looking for. And it is so important, like Dr. Affolter said, for prognosis and for treatment, that if we don't have that report back before we see someone, I will always preface the conversation with, you know, I'm going to talk to you as if this pathology report that you have is correct, but you need to know if my pathologist says it's different, we may be having a different conversation. Either way, it could go either way, but that I'm going to rely on their pathology, you know, our pathology report. Just again, because with it being such a rare cancer, you know, because we do HIPEC, we see a lot of people with appendix cancer here. And so our pathologists get very familiar and are up to date on the nomenclature, on the characterization, which seems to be changing almost yearly.
Very much so. It's hard to keep up with. And again, I'm also grateful for Dr. Lambert coming in 2018. We didn't see a lot of these before that, but over the last couple of years, my team of GI specialist pathologists has really delved into the literature. I think we have a really good understanding of it. We have a large team so that we can show one another and make sure we all agree. It's a really nice place to be practicing this. And you know, we bring it to treatment planning conference when Dr. Lambert has a question, and we can discuss it from a multidisciplinary approach, so that we can all be on the same page. It's really nice to feel like we do have a good understanding of it here. Oh, and I know what I was going to say. There was a question also, you know, about with all the virtual visits and coming from long distance. You know, your pathology, if you've got it and had your incidental appendectomy that has the pathology in that, you can have that sent ahead of you coming, so that by the time you come to a visit, you know, the discussion can be accurate. You can do it afterwards too, as Dr. Lambert was saying, but if you know ahead of time, that's separate from your body at this point, so it can be sent and looked at.
Thank you guys so much for answering that question so thoroughly. So another question that I have is, again, for you, Dr. Affolter. We've noticed recently a lot of new patients joining a support group with a goblet cell pathology. Do you feel that it's on the rise? And how does this pathology differ from other appendiceal tumor pathologies?
I'd hate to assume that it's on the rise. I don't know the literature on that for sure. I think if anything, it is probably, if the numbers are showing that it's on the rise, I would wage a bet that between radiology being better and being able to see lesions, and then also our awareness of that lesion have both gotten better over the years. And so I don't know that it's not truly on the rise. But I know our awareness has increased of that lesion, and it's also has a different name now, so that can be confusing to people as well. It used to be called a goblet cell carcinoid, and now it's called a goblet cell adenocarcinoma, and there's grades 1, 2, and 3 of that. And it's, you know, we're still understanding it. It seems to have it's still a mucinous neoplasm of the appendix, but it is distinct from these low-grade appendiceal mucinous neoplasms or high-grade or even signet ring cells. And it's also separate from if anybody has neuroendocrine tumors. It's kind of this tumor that almost splits the middle, even though it's definitely a separate and distinct entity.
It'd be interesting to see what the genome expression is, the gene expression profile is of that tumor. I'm sure somebody's looking at that separate from, compared to other types of appendix tumors.
Yeah, I've seen like RNA expression profiles of that, and it is different. I don't remember the details, but it's different.
I'll bet it is. Yeah.
Thank you so much. All right, so now I have a question for Lawrence. Patients that undergo CRS HIPEC, it obviously is a massive, very invasive surgery and can be very hard on them. What is some advice that you have for patients going into it, knowing that they have to prepare to have the best post-operative experience following the procedure while they are inpatient?
I think pre-procedure or pre-operation education is critical because they really kind of need to know exactly what is going to happen post-operatively. So we really rely on, Dr. Lambert and her team in the clinic to do a lot of great preoperative teaching to know what that journey is going to be like. During the first 24 to 48 hours, depending on how well the patient is doing, we do always like to let them know that they will be spending at least one night, possibly 2 nights in the ICU. And that's really just to keep a very close eye on them. And, when you're in the hospital, it's not a place that you vacation or get sleep, unfortunately. And so the first 48 hours are a little bit rocky, only because you don't get a lot of sleep. We're keeping a close eye on you just for your safety and doing a lot of monitoring. And then after the fact, it really is that although it seems counterintuitive, with the good pain control, we want to get people up and moving. That's really, really an important. Dr. Lambert says it's okay to get up and moving. We really want that to happen. And that don't hesitate to say if you're having pain, because this is very painful. And people get very scared about using a lot of pain medications. I am just totally amazed with how Mark did with his recovery and doing the short-term path. Adults don't seem to do as well as kids do on something like that. And the pain can be hard, but we also want to be the cheerleaders at the bedside as well, to be able to get people up and moving and saying that, really letting them know that what they're experiencing is generally the normal path to recovery. And so once we are able to reassure them, then I think that goes a long way to getting them up to movement and getting hopefully home soon. Did I miss anything, Dr.?
No, I think you did a nice job. Yeah, I think complications of the surgery, it's still hard to imagine, and until you've kind of gone through it, until somebody like Mark who's gone through it, you don't really know what it's like, I guess.
Thank you guys so much. Kind of going off of that, what kind of palliative care and symptom managements are available to patients at Huntsman who have undergone CRS HIPEC?
So that comes back to the team that Lawrence mentioned earlier. So we have a wonderful supportive oncology service that is available to help us if we do run into a situation where somebody's symptoms after the surgery are more challenging to manage than usual for whatever reason, if they're having more pain or nausea. And that can happen, if somebody has had a lot of chemotherapy prior to the surgery, they may be more sensitive to the HIPEC and have more nausea that kind of gets beyond what we normally use to treat it. And we have that group of experts to help us with that. And in addition, it's the nurse practitioners who staff the Huntsman at Home team that will follow the person into the home after they leave the surgery, are all certified in palliative care. So they are experts, not only in, monitoring the wound and making sure the person's not getting dehydrated, but managing pain and nausea and other symptoms like that. So it's a huge part of what we do. We believe very strongly in palliative care and their early involvement with patients. A lot of patients who have advanced cancer right at the time of diagnosis. I think it's really important to get them involved as part of, like what Dr. Soares said, the multidisciplinary team that we provide and the resources that we have just to get everybody available to help.
Thank you. So we do have a question in the chat from Kelly. As someone who, this is her question, as someone looking at a second CRS HIPEC, how common is it to return to the original surgeon versus going to a different surgical appendix cancer specialist?
Yeah. I think that's a hard question to answer. I don't know of any actual data around it. My experience, at least my personal experience as being a HIPEC surgeon and from my colleagues, is that most people do stay with the original surgeon, but that's not a hard and fast rule by any chance. Circumstances change, people move, families change locations and stuff like that. Or if there just wasn't a great connection between the surgeon and the person and their family, people will often look elsewhere, to find somebody else who can do their surgery. So I guess the best way to answer that question is I think most commonly people will stay with the same surgeon, but it's not 100%. Certainly people do go elsewhere.
Yeah, I just want to add to kind of patient perspective that you have no obligation to your surgeon. So if you're not feeling like you're getting at the highest standard of care, that we always tell patients to seek different opinions. So really it's up to you. You can always kind of go out of your realm, obviously, given travel constraints, and if you don't have a specialist near you, it is harder, but we always tell people that getting multiple opinions from people is really important too. So we have about 7 minutes left, and I do have a question that I think often comes up. I don't know how much it was touched upon in the general session, but obviously you all can speak to it about specifically to Huntsman, but what are some best practices for handling ongoing pain post-CRS HIPEC for patients?
I guess it depends on the nature of the pain, right? And it's, everybody has different pain threshold, different tolerance for pain. People are in different circumstances. So somebody it's their first surgery versus somebody who's having their third HIPEC, that certainly is a possibility. Whether they had a pain pre-existing the surgery, whether they were on pain medication prior to the surgery, it all complicates the management. So I don't know that there's definitely not a one size fits all in that regard. I think here what we would do is, if it was one of my patients or somebody that I was taking care of, I would certainly engage either our supportive oncology service or our acute pain service, because there are a lot of new techniques that we can use for pain, regional therapies, different adjuncts to pain medication. As everybody's aware, we're as a country, we're really trying to avoid using opioids as much as possible for the issues around addiction and that sort of stuff. So we've definitely got, pain specialists and pain experts. And I think once somebody sort of gets off the normal track, that would be my recommendation for that person, is to get in to see one of our pain specialists and see if they have something else to offer.
Thank you. Well, we have 5 minutes left. I don't see any questions in the chat. We've touched upon everything. But if anyone wants to add anything from the panelists' perspectives, we have some great panelists here and that are taking time out of their crazy schedules. So if you guys have anything that you want to add to the attendees, you're welcome to, and kind of roll from there with the last few minutes left. Or Dr. Lambert, anyone?
Hi, sorry. I just want to add, and I can add this because I joined in December, and coming from different institutions and having different perspectives. I'm also a chronic patient myself, as well as my daughter, and I have been so impressed by the College of Care that the University of Utah and the Huntsman Cancer Institute have given to patients. So it takes a village to take good care of patients, and I think this institution offers amazing village to provide care. So I didn't know that Dr. Lambert had only joined in 2018. So what an awesome addition to Huntsman. So thank you all, and thank you for allowing me to join today.
Yeah. I would absolutely echo that. So I've just been so impressed with the fact that the fact that Huntsman is a standalone cancer hospital in a major academic center, but everybody that's here, that works here, I mean, everybody that works here understands that the people who are coming here either have cancer or they're with somebody who has cancer. It is in the water. They are unbelievably compassionate. They work together as a team. Like I said, when I first came here, just getting the HIPEC program organized. When I got here, everything was up and running and ready. I've started another HIPEC program at another institution. Basically, I did it with, bubble gum and duct tape. And it was kind of like, if you want to do HIPEC, that's fine, go ahead. So it was, I just echo what Dr. Soares has said. We have a wonderful group of GI medical oncologists, our pathologists, the nurses are terrific. And it's been just a privilege to be here, and grateful that we've been able to provide this service to the Intermountain West and the people that live in this region.
Thank you so much. Well, you can see the chat. Everyone is very excited that we were able to have this program, and thanks to everyone today, panelists. I know Dr. Lambert has a big fan club, so this has been awesome. I just want to say thank you all again. Thank you for submitting questions, for joining us this afternoon. Thank you to our amazing panelists. They're all, as I've said, very busy, I'm sure. So taking an hour to share their expertise and answer some questions has been awesome. And thank you to Mark and his parents today for sharing their story. Yes, the real reason why we're all listening and tuning in. No, I'm just kidding. But no, thank you so much. And thank you. If anyone has questions about ACPMP, they can email info@acpmp.org. And as I've mentioned, every part of this session, general and these regional programs, will have been recorded, so they will be available to view afterwards. We're going to work on them and get those links sent to everyone's emails. And with that, I'll turn it over to Dr. Lambert just to say a final word. And so thanks again.
All right. Well, thank you, Lauren. And I want to thank Mark and Ryan and Melinda for sharing your story. It was inspiring, to say the least. I want to thank Lawrence and Heloisa and Kajsa and Emily for supporting the symposium. And just a huge shout out to the ACPMP Research Foundation, who have really led the charge in education, awareness, and research for appendiceal cancer. And we couldn't do this without them. They're a huge resource for us and for patients and people who are dealing with appendiceal cancer. And it's just been a great privilege to work with them as well. So thank you all for joining us. Hopefully next year we'll be in person.
Thank you, everyone. Bye.